Okay, so good morning, everybody. My name is Dylan Ely. I am the UC Davis EMS Fellow. Talk I'm giving today is going to be on opioids and methamphetamines. This is obviously something that we see all of the time, both in the field and in the hospital. And I thought it would be a good thing to kind of go over a couple of things, both the medical aspect of things as well as why are we seeing so much more of this? Why is it becoming worse of an issue? So why does it matter? So these are the health statistics for this past year. As you can see here, in the 1 year period leading up to April of this year in the United States, there was over 100,000 drug overdose deaths. That's compared to the average, which is around 70,000 in the 1 year period. So this is up, almost a third. A lot of factors that go into this. Partial is likely the pandemic. There's a lot more people that have anxiety issues, depression issues, a lot more people that have started drug use because of unemployment and all of these other social aspects that go into it. Additionally, a much higher percentage of these are coming from opioid overdoses, and a lot of these are coming from synthetic opioids, right? So we're not talking about heroin overdoses, we're talking about fentanyl overdoses for the most part. As we know, there's a lot more fentanyl. And the question is, why? As you can see, from January to July of this year, there's 140 fentanyl-related deaths that's just Sacramento County. As you can see, District Attorney Crime Lab in the Sacramento area, of all of the narcotics that are seized, a lot of these are the fake oxys. Essentially what's going on is a lot of these drugs are coming into the United States from either Canada or Mexico, where they're kind of essentially created in labs, right? These are like high quality synthetic drugs that are mostly made of fentanyl. A lot of these drugs end up coming from, is mass produced in China, gets illegally shipped to either the United States in some small quantities, but mostly Canada or Mexico. And there are these large labs that have, organic chemists and everything else in them that can turn these things into pills that look very convincing. But it's still happening in an unregulated space. So a lot of these pills are made up of fentanyl and then whatever filler. So a lot of these pills aren't kind of mixed properly. So you have pills that contain 1 milligram or 2 of fentanyl, right? And that is a good clean kill every time if you take 1 milligram of fentanyl and you don't have any Narcan or you're unaided. So that's where this, the idea of one pill can kill, right? So I know I have been on calls with Metro where you go and it's a pretty normal-ish seeming person saying, oh, I only took 1 oxy after you give them Narcan and they wake up, and you're kind of like, come on, bro, like 1 oxy isn't gonna do this to you. It can. If it's a fake oxy, it certainly can contain enough fentanyl to kill somebody. And additionally, testing other counterfeit medications like Xanax, like Adderall, all of these things, a lot of them are containing fentanyl just because it's so cheap that it's coming into these other countries and just getting packaged up with these other drugs. So that's where you're seeing people that think that they're doing cocaine and then it's a fentanyl overdose, or think they're taking Adderall and it's a fentanyl overdose. It's just because these medications are getting cut with other things before they come into the United States, which is what is driving this massive amount of increase in overdoses and deaths. So this is what I'm talking about, right? So this is, the top one there is a legitimate oxycodone pill, right? So it's, as you can see, the bottom one there actually looks more professionally made, honestly. And that bottom one is mostly just fentanyl. So people that, some of the driving factors around why people get addicted to opioids and end up doing opioids is, some of it does come from people that have legitimate prescriptions that they take for a while that they either run out of or, for good reasons, their primary care or whoever is trying to cut them down on them, and they go out and they try to buy more on the street, right? So even if you knew what these pills looked like and you knew what you were looking for, you could still very easily end up taking the wrong pill, essentially, and getting a huge dose of fentanyl and dying from that. So this is just kind of another rundown of sort of the typical pathway that these drugs take. Again, a lot of the fentanyl is just kind of produced in China, and very small amounts actually come directly into the United States. It actually mostly comes through the Postal Service, where you can kind of ship these small numbers, and some of it's going to get through. But when you're talking about kind of the massive amounts that are needed in order to just produce all of these drugs, most of them are coming from either Canada or from Mexico, where again, they're being shipped to labs that produce large amounts of these pills to then come down into the United States. But this was about 650 pounds of fentanyl that was seized crossing the American border, I think in Arizona. So as you can see, like, it's not small amounts, it's all very professionally packaged. This is all just like, this is what comes in and gets cut with cocaine and meth and all of this other kind of stuff. Okay, so why is fentanyl such an issue? So it all kind of comes down to the mu receptor, right? The opioid receptor that these drugs attach to. And different drugs have different affinities, right? So we kind of think of everything in relation to morphine, which is kind of like your, what we'll call like your standard strength opiate medication. And as you can see, as you're kind of walking across there, all of these different kind of versions of that up to fentanyl, which is, 50 to 100 times stronger at binding that receptor. And in addition to that, it also has the ability to cross the blood-brain barrier more quickly. So you have like a stronger medication that has more of the sedating effect and more of the respiratory depression in larger doses. Why do these Narcan doses end up needing to be so ridiculous, right? I think we've probably all been in the situation where you give one of Narcan and they still are out, and you give another one of Narcan, and you put a line in, and you give them some more Narcan, and then they start to wake up, right? It's because of this. It's because of the affinity. So Narcan is what we call a competitive antagonist, which means that the way that it works, the way that it bumps that medication off of the receptor is concentration based. It's based off of the amount that's there. So something like fentanyl, you need a lot more to be kind of forcing that medication off the receptor in order to actually have the effect. So, and then not only that, but like as some of it, as you often see, once it bumps the fentanyl off of the receptor, Narcan, the concentration starts to go down, and a lot of the case, the person, you lose that competitive edge, and the fentanyl goes back onto the receptor, and they re-overdose, right? Fentanyl tends to be, it doesn't have the same kind of half-life as heroin or morphine does, but when you're talking about these doses of, if you take 1 milligram of fentanyl, that's going to be in your system for quite some time, and that's where you have to worry about redosing and redosing and redosing Narcan, because they will quickly overdose again. And then, so this is an interesting point. We've probably all heard of this, can you walk into a building and open a drawer and fentanyl dust gets in your face and you overdose, right? There's actually quite a few news articles when I was looking into this of mostly police departments going on like a drug bust and going into a house and coming into contact with it, or coming into it, seeing stuff in the air and then thinking it's fentanyl, and then either going to the hospital, or in many cases, some of them even have sort of the symptoms of feeling like they can't breathe, collapse, syncope, that kind of stuff. It is actually pretty close to impossible to have an actual overdose from fentanyl in those circumstances. Outside of a production facility where you're literally, will have like clouds of fentanyl in the air, you're not gonna inhale enough fentanyl to overdose. Basic PPE, having gloves on, you could stick your hand into a pile of fentanyl and not overdose from it. The patches that we make that are fentanyl patches that you sit on someone's skin, take hours and hours and hours to actually have this full effect, and they're designed to do that, right? The transdermal exposure isn't really much. So a lot of the cases that we see of people that are, having the shortness of breath and feeling like they are going to pass out, it's mostly just stress response, right? So it's mostly, everyone has heard these stories of people overdosing from being exposed to fentanyl in the air or picking up a package, and you have kind of the equivalent of like an anxiety attack and have those symptoms. But medically speaking, going into a house, even if it's a house where there's a ton of fentanyl around, really not going to be able to overdose just from being exposed in that way. And that last bit there, so that was a actual journal article that looked at newspaper articles and newspaper reporting on this topic, and found that there's hundreds and hundreds of articles from 48 states that all are stories of like this contact overdose, and looking at the amount that's shared compared to the usual response, which is then some corrective thing that is, from either a medical journal or from someone in the medical profession saying that this isn't really possible in this situation. And of course, no one reads that one. Everyone reads the story where, you think that someone inhaled a bunch of fentanyl and died. So it's kind of like this collective media hysteria that people have had, and it's just, fentanyl is a scary drug, and there's a lot of it around, and I think people just kind of let these things make them more anxious. But you always, but medically speaking, you are safe as a first responder going into these situations, and if it's an exploding fentanyl factory, maybe hold off, but otherwise you'll be okay. So most common signs of opioid overdose, right? Like we all know this like the back of our hands, right? The pinpoint pupils, the respiratory depression, the blue lips from central cyanosis. It's a common complaint that we respond to. Commonly, it's things like person found down or person not breathing. And I think the importance of this is just realizing, with sort of all of the other issues around fentanyl coming on, you should be looking at this for anyone who fits this criteria, right? Whether it's someone found down, even if everyone there is just saying he did a bunch of something else or we're just doing whatever. A lot of the times people that are overdosing from fentanyl and people that are getting into this situation don't know that they took it, right? So if it walks like a duck and it quacks like a duck, it's probably a duck, right? No matter what anyone else there is telling you, it's important to think about it. And if you're thinking about it, just trying Narcan, right? It's a very safe drug. There's not a lot you can do other than give too much and make someone very unhappy if they are actually overdosed. So as far as once you do recognize that someone is overdosed, again, that is just an image of competitive antagonism, the Narcan displacing whatever opioid that is. Again, just keeping in mind that dependent on what that is, its ability to bump it off and keep it off is kind of variable. And then, obviously the life-threatening problem with an opioid overdose is the not being able to breathe, right? So whether you need to put in an OPA and start bagging someone while you're giving Narcan, sometimes you need to put in an LMA or even intubate them. It's important to, if it looks like that's what it is, keep trying the treatment, right? Because for like I was saying, for like a milligram of fentanyl, 2 milligrams of IN Narcan are probably not going to wake you up, right? You're probably going to be pretty far overdosed. So trying multiple doses is definitely something that you should be doing, and people do if you have a high suspicion. And additionally, something else to think about is if you're giving multiple doses of nasal Narcan, you can kind of oversaturate the mucosa, right? So think about it. You're putting in a milliliter or 2 milliliters of fluid that's going into the nasal space that's supposed to be absorbing through the mucosa. But if you are putting in 4 or 5, however many milliliters of fluid, there's going to be some reduction in the effectiveness of it crossing that, right? So some reduction in the effectiveness of getting that medication through your nares. Multiple redosing, recurrent overdose. Just that, while in transit to the hospital, it's important to kind of keep an eye on what's happening, right? So just because this person has been reversed doesn't mean that they're not going to overdose again. Just because, you can see that they're breathing 10 to 12 a minute doesn't mean that 2 or 3 minutes from now they're going to be back down to 1 or 2. So just kind of, it's an active process when you're transporting these people to the hospital. Other things you can do, I know like what I like to do in the emergency department if someone is still pretty sleepy and hanging out after they've been reversed is you can put Untitled on them. The same way when people are if they're decreasing the amount of respirations and they're decreasing the effectiveness of the respiration, so they're breathing really shallow, their Untitled CO2 is going to start to creep up, right? They're not they're not ventilating effectively. So, you know, if you're concerned that someone is, you know, maybe at risk of re-overdosing, it's definitely worth throwing the end title on them to help kind of keep track of some extra data. And then so overtreating. So this is kind of one of the difficulties with fentanyl, right? Is especially in chronic users, people that use all of the time, if you give them a big whopping dose of Narcan, they're going to become super unpleasant, and they're going to be diaphoretic and nauseous and vomiting, and no one's going to enjoy that on the way to the hospital, right? But the flip side of that is there are more people now that need these really large doses in order to kind of get back to a place where they're going to be stable from a respiratory standpoint. You know, it kind of depends, and different people have different opinions on this. When I've talked to some of the toxicology people at the hospital, and their idea is just totally reverse them, then you know what you're dealing with, and you know, if you need to sedate them because they're super unhappy and anxious and even agitated, then that's what you have to do, right? Easier said than done, I feel like. But I think that if you're going to reverse them, you at least need to get them to a place where they're breathing 10 to 12 a minute, where they are somewhat responsive, where you know that they're at least, you know, if you put an end title on and it's 30, great, then I think you can probably let that ride for a little bit, versus needing to kind of fully bring them out. And then so just so you guys know, once they come to the hospital, what do we do for them? It varies quite a bit. So after someone has overdosed, we typically like to watch them for 6 to 8 hours. This is to look to see if they need to be redosed with Narcan. Because again, you know, like the half-life of Narcan is shorter than a lot of these opioids. So it's possible to sit there for a couple of hours and then re-overdose and need another dose. If that happens, that's someone that gets admitted to the hospital. And there have been plenty of times where people are needing it on an hourly to every hour basis, and those people can actually get put on a Narcan drip and go to the ICU. The other side of this is, so what do we do after the overdose, right? So it's interesting. There was a big study from, I think it was in Massachusetts like a year or two ago, that looked at what happens to these people after they get discharged from the hospital. 1.1% of these people end up dying of a opioid overdose within the next 30 days. And 5%, I think 5.5% within 1 year, right? So there's not a lot of things that we see on a regular basis that have like a 1% 30-day mortality, right? Like that is phenomenally high. And same thing, a 5.5% year mortality is also very, very high, right? So this is why it's important for these people to end up coming to the hospital, because we've gotten much better on the hospital standpoint of trying to start these people on Suboxone, right? Trying to do something, some kind of risk management, because it is just, it's very high risk, right? These people have a huge chance of dying in the next year, and it's our responsibility as physicians in the hospital to try to prevent that. Similarly, I know we have the same issues in the emergency department as you guys sometimes have in the field, where you reverse someone, they're now alert and oriented, and they do not want to go to the hospital, they want to get out of there, right? That is a huge issue. There's a lot of places where those people are not allowed to AMA. You actually call PD to help assist you with that. I don't know if that's the right choice versus just trying to get them to understand the danger that they're in, understanding that just because they're awake and breathing right now doesn't mean an hour from now or even 30 minutes from now that's still going to be the case, and that it is much safer to be transported to the hospital where you can be monitored, where you can be started on medications you might need, than to just get out of there. Now, don't chase them down if they turn and run, obviously, but you know, I think it's important to let them know exactly how dangerous the situation that they're in is. Okay, so the other one, methamphetamine. So this is obviously a massive issue in California and in Sacramento. I actually trained in medical school on the East Coast, and there's almost no methamphetamine when I was there, which was really interesting. Yeah. we had much more opioid overdoses. We saw that, we would have multiple every single shift for the most part, but meth was much less of an issue. But it actually has become much more of a country-wide issue in the last several years. A lot of this, it's thought to be that there's been this really aggressive push with the opioid epidemic, and it made it easier to transport and to get, to sell and get rid of methamphetamine, just because it kind of went more unnoticed than some of the other stuff that was really being aggressively gone after. It typically, so it's an amphetamine type medication, right? So it basically works through the dopamine receptors, which is like your reward pathway, right? It just makes you feel amazing. But meth is a very dirty drug. It affects a lot of other pathways, and you can see that in, the sort of some of the other side effects that it has, right? Like the psychiatric issues that it causes, the movement disorder issues that it causes. Those are all neurotransmitters that are getting kind of agitated. That isn't just like this dopamine release that is, kind of the main addicting part of methamphetamine. Unlike opioids, which have a direct kind of pathway to overdose and death, right? Respiratory depression. Methamphetamine, less so. There's a couple things that it can cause that can kill you, while you're overdosed on it, which is, like a heart arrhythmia, you go into VTAC or VFib just because you're so overtly agitated. Hyperthermia, right? These people can become so kind of hyped when you're trying to sedate them, or just when they're out running around, that their actual core temperature goes up so high that it can cause, fatal arrhythmias or acidosis or all of these other things. But most of the things that cause mortality in the end are not related to that, right? So it's like the meth-induced cardiomyopathy. These are like the 30 and 40-year-olds that have end-stage heart failure, right? That's what ends up killing them. Or psychosis, right? Like these are the people that come in because they are just completely out of their mind and have no idea what's going on. It's regular use of methamphetamine can lead to long-term psychiatric illness, which in and of itself is a risk factor for mortality. And then, all of the other stuff that comes along with it, dental decay, movement disorders, all of the typical meth-related things that we see. Just like opioids, in the last couple of years, methamphetamine has really taken off. The number of meth cardiomyopathy, or like the meth heart failure admissions to hospitals has gone up, 5-fold in the last couple of years. The amount of spending that the healthcare system has to do on these kind of meth-associated pathologies is up 800% in the last couple of years. Not to the same extent as opioid, the amount of increase in death and mortality and all of these bad issues, but meth is pretty close behind it, even though it doesn't kind of get the same amount of press, I guess, as opioids do. And then so why is it becoming worse other than just the amount that's out there? So the way that meth used to be made was you got ephedrine, right? You got like the nasal decongestant stuff, and you cooked it down and you made what was essentially amphetamine. All right, so this was, you had to steal large quantities of this ephedrine and you cooked it down, and this is how it was made in the 80s, and you got like a relatively clean drug out of that. But ephedrine became much more tightly regulated, got a lot harder to get a hold of, and so people that make these drugs had to figure out something else to do. And they kind of came up with this new way of making meth that uses all of these highly toxic chemicals and cooks them down. And this is where you start having like these explosions and exposures and all of this stuff in these labs, because these labs have organic chemists that are doing this. It's like not basic science anymore, and it's very, very dangerous. But the side effect of that is you have a drug that has a lot more of the side effects of methamphetamine and it's just not as clean as a drug, right? So this is why we have a lot more meth-induced psychosis, we have a lot more heart failure, we have all of these things that if you controlled for the same number of people in the 80s when it was a very different drug, this is kind of a newly developed issue. And again, coming out of a lot of the same places in Mexico and Canada where fentanyl and the other drugs are coming from. So it's not that uncommon to have a mixed overdose, like an unintentional mixed overdose. And then again, this is something that we all see all of the time and we're very familiar with, but it's much more variable than just an opioid overdose, right? This is the person running down the street. This is a person who is unconscious. This is a seizure. Lots and lots of things. It's actually a huge, a large component of this ends up coming as trauma activations. These are people that end up getting in car accidents or jumping off of something or getting in a fight. All of that kind of is the picture of what we would call like a meth overdose or a meth acute intoxication. So how do we deal with it, right? So the biggest, I think, issue and the biggest thing that people think of when they think of meth toxicity is like the excited delirium, right? So this is like the person who is so amped up, you can't reason with them, they're fighting you, the police are there, they want you to transport this person to the hospital, right? Because they're like essentially actively psychotic. You know, no one enjoys this call, right? This is like the worst call, one of. But I think it's important to remember that this is a potentially fatal medical situation, right? Like these people die from this. This is why it's important to remember, you know, when these people do need to get sedated, when these people do need to get restrained, it needs to be done correctly and safely, both for you as the paramedic and for the patient, right? So this, you know, a lot of places have kind of moved to using ketamine for this because it's a much faster IM drug. That is not approved for this in California, unfortunately or fortunately, depending on your take on it. So we use the IM benzodiazepine, IM Versed, right? So the time of onset for that is in minutes, double digits minutes, right? Like 10 minutes probably if you're gonna actually take someone down by giving them IM Versed. So it takes a while. And it's just the way that the toxicologist at UC Davis that I talked to describes this as what he calls like the benzo bucket, right? These people can require massive amounts of benzos in order to actually become adequately sedated. And everyone has a different number, and you just keep filling up their benzo bucket until they go down, more or less. I think that this is probably the primary reason where these people kind of come into our realm, right? Like a lot of the times if people are just having psychiatric issues, sometimes they'll call 911. A lot of the times they will come in themselves if people are having rapid heart rates or just feeling agitated or feeling, you know, like chest pain. A lot of them present themselves. This is where we see like meth overdose, right? And I think that it's important for us to recognize how to kind of to do it safely. Because again, it's very similar in the emergency department where, you know, it's just supportive care, right? It's getting this person to a place where they're safe. But these people can become so agitated and require so much medication that you need to, you know, in order to adequately sedate them, they need so much medication they need to be intubated, right? Because they no longer, you know, the amount of benzodiazepines that they're requiring. Some of these people, even when they're sedated, they have so much like psychomotor agitation where they're just still tremoring, they're still tensed up. Well, you actually need to intubate them and paralyze them. They can drive up their core temperature so high just by being flexed and agitated that they need to go to the ICU and be paralyzed. So, you know, it's a call that nobody likes, and it's a call that kind of sucks, but you know, it's a medical emergency as much as a STEMI is, as much as any of the other things are, and I think it's important to kind of remember that when you're really annoyed at the fact of like how difficult these patients can be, both just physically and just like emotionally dealing with a lot of this stuff. So this is another thing that has kind of come out of the current state of fentanyl and other drugs is the mixed overdose, right? So this is the person where you show up and everyone says that they were taking meth and they very clearly are an opioid overdose, and you reverse them, and then now they are excited delirium, you know, freaking out, unable to control them. You know, it's a very tough situation on how to deal with this. Again, I spoke with several different doctors about this. Everyone is kind of on a different page. I understand the hesitation of fully reversing people that you might have a suspicion of this, or you've been told that they thought they were taking meth and they had an overdose, right? Because it can be very dangerous to put this person into a state of excited delirium and then need to sedate them, right? So, again, the toxicologist at UC Davis that I spoke to said that that would be the way that they would do it. They would just fully reverse them, deal with the consequences, even if that meant sedation and restraining them. His perspective of it was, at least then you know fully what you're dealing with. It's versus trying to kind of thread the needle of just reversing them enough that they're kind of breathing and doing their own thing, but not quite enough that they are in that state of agitated or excited delirium. I think from the perspective of the pre-hospital, again, I don't know how realistic that is, I guess, right? Because if you're going to be stuck in the back of an ambulance for this person for 15 minutes driving to the hospital, do you really want them to be in that state? Again, I think that this is where, if you're going to try to do a minimal reversal or reverse them enough, this is someone I would put Untitled on, right? Kind of keep track, making sure that at the very least they're having effective ventilation so that that they haven't overdosed again. It's a difficult issue, and there's one that there's really no clear answer to, I guess, which is, I know this was kind of the question that drove this whole talk today. And unfortunately, I don't have a great answer other than you would be very warranted in whatever approach you kind of took, but I would pick one. I would pick either you reverse them and you're going to tie them down and sedate them if necessary, or you do minimal reversal and you put Untitled on them and you make sure that they're safely monitored. Anything in between, could potentially be dangerous either for you or for the patient.